Thank you so much for joining us today. I am excited to be able to introduce Steve Chazen, VP of Product Management of Alarm.com. We very much appreciate the support from Alarm.com in our research and across our events each year, and excited to talk to Steve today a little bit more about the connected health space and the smart home industry. So welcome, Steve. Thanks for joining us today. It is a great time to be in the industry, and our Q1 2021 consumer research shows that now 64% of consumers are using telehealth services, up from 15% in 2019. And this is really just an example of how behaviors are changing for consumers as a result of the pandemic. I want to take a minute and allow you to introduce yourself, tell us what you do and what you're working on, and then ask you a few questions about the future of healthcare.
Thank you, Elizabeth, for having me. I manage our partner tools, our business intelligence, and our wellness vertical at Alarm.com. And I've been at the company for about 3 years, spent most of my career in enterprise and consumer brands. And I think I'm at the right company at the right time in the midst of the consumer changes for healthcare.
So that's great. And tell us a little bit about some of the things that you've seen specifically in the past 18 months. We've heard that the pandemic has been a huge catalyst of change, not only for consumers, but healthcare systems. So what are some of the takeaways that Alarm.com is seeing in the market?
Yeah, there's a couple of them. The first one you mentioned about telehealth and telecare. Any way you can avoid a trip into a hospital or a doctor's office, it's good to use technology to do that. About 1.5 years ago, we launched a product we called WellCam. You can kind of see it over my shoulder there. It was a camera dedicated for this purpose. You put it in a consumer's home. Family members, caregivers can look at them, make sure they're okay. And if they need help, they can press a button, have a two-way voice conversation. We saw that pick up pretty dramatically during COVID, including hospital systems, one major one in Kentucky, who put these in pop-up ERs because they were running out of PPE and they needed another technology in order to have care delivered to the bedside of these patients. It's pretty incredible that we were fortunate to be part of.
Oh, yeah, that's great. And it's amazing how quickly hospitals have been able to shift their operations to integrate technology. Can you talk a little bit about the role of voice and artificial intelligence? All of these things require integration, broadband, and really a continuous offer for consumers to have the experience that they need to have as it relates to healthcare.
Yeah, Alarm.com pioneered the connected home 20-some years ago by putting a cell radio in a security panel. And we've led the market ever since, especially around two-way voice, so that if somebody needs help, they can get it. We can connect them to the monitoring station partners and they can get what they need. You can imagine that expanding in a post-COVID world where their security solution can provide them help as and when they need it. We're also seeing a couple of other trends in the last, I would say, 5 years, which are very interesting and ones we probably wouldn't have imagined. One of them is the fact that now the mobile phone that many of us carry around has become the central store of health data for a consumer. In the past, our records were stored on paper in a physician's office, and now my phone has more up-to-date information about my health than maybe my physician has, and I can take that with me. And then the second thing that we're seeing, again, probably none of this was expected 5 years ago, and it's only gone more dramatic during COVID, is wearables and services that consumers gladly pay for in order to stay healthy. You think about Apple Watch with an Apple Fitness Plus subscription, or a Whoop band, or a Fitbit, Amazon Halo. These are tools now providing insights and suggestions for people to stay healthy, where before they'd have to see a doctor who would then give them the insights and suggestions to get healthy. So you're seeing this other angle around people taking ownership of their health, and it's pretty remarkable.
It certainly is, and certainly some of the capabilities that we're seeing with smartwatches and the wearable devices to be able to track specific vital signs and bodily functions that can help with predictive and or proactive types of analytics. That also leads to the idea that technology can enable people to live in their homes longer. And so that independent living segment, the seniors who continue to get older as we all do, really wanting to stay in their homes, and family caretakers wanting to make sure they're safe. Can you share a little bit about how Alarm.com's solution really impacts that caregiver market and those seniors living at home independently?
Yeah, that actually is one of the things we've been doing for over a decade. Very proud of that. Our wellness solutions turn the security panel and the sensors in your home into a different kind of offering so that we can look at patterns of behavior. How often are they moving through the home? How often have they left or come in? Have they changed their behavior? Are they safe inside their home when they should be? And that information informs dashboards powered by AI, which then is provided to a caregiver or a family member to have an understanding of what their loved one is doing so they can be in front of problems and trends before they become issues. It's probably one of the most understated, but probably transformational components of our platform that we've seen, and that business has been in high demand.
Sure, and I can certainly see that that pitch of spending hundreds of dollars a month versus maybe thousands a year, as well as keeping people in their homes. I don't think anybody really wants to have to move out of their home into any facility. So I was just talking to somebody about those average costs of facilities and how they're just astronomical, and nobody wants to be there in the first place. So a lot of work that can still be done to keep people in their homes and safely. Let's talk just for a minute about the future of healthcare. We've seen dramatic changes in 18 months in the past, and we have the next 18 months that look like a little rocky maybe. How would you characterize things moving forward in the next year to 3 years out?
So I think that if you look at now that consumer health data is available on every smartphone, it's ready for companies like Alarm.com and others to create these new connected health solutions that we couldn't do before. And one example of something we're working on is in the same way that our system notifies a homeowner that a window has unexpectedly opened at an odd hour. We don't know if it's you getting a breath of fresh air or an evildoer trying to climb in your window, but we notify you that something doesn't look right. In that same way, we can notify family members or caregivers if a loved one may experience a high heart rate, low blood pressure, maybe they've just got a positive COVID report. That piece of information often stays locked on the phone. You can imagine using our system to communicate that to people that care about them. The other component of this is, and it goes back to kind of democratizing access to better healthcare. In the same way that like PCs democratized access to computing. If you remember back in the day, you had to be in a mainframe. You had very little access to the power that was in that room. Now we all have PCs. In fact, we have hundreds of them all around our home, in our phones, on our watches, our microwaves, our robot vacuums. And we see the next wave of connected health as a fusion of the sensors that are in our homes, in our cars, on our bodies, in our offices, all looking out for changes or trends, and then turning that data into insights and those insights into action. I call this ambient awareness, which is essentially using data across a variety of devices to provide this loved one and their family with an understanding of how things are going.
Well, I really love that ambient awareness. That's awesome. And certainly Alarm.com is playing a huge role in the industry to push things forward for the consumer. It is all about the experience, and especially within healthcare, how can we help people remain in their homes safely and longer? So Steve, I want to thank you again for your time today and for Alarm.com's support of Parks Associates research and events. Thank you for joining us, and look forward to seeing you in person soon.
Thank you for having me.
If you miss a live session, you can go back at any time to watch on demand. Go to Watch Replays and click on the session that you want to view. Have you created your own event agenda in SwapCard? Visit the Agenda and Watch Replay tabs to add sessions that interest you to your own event. You can go back to My Event to revisit any bookmarked sessions, sponsors, and items. We want to make sure that you're connecting with our industry-leading sponsors. You can interact with them by visiting the Booths and the Sponsor tab. You can also bookmark sponsors or add items to your event to view later. Sponsors have uploaded extra materials for attendees. Make sure to visit sponsors that interest you to chat with one of their team members or save documents for later. We have dedicated meeting slots set up for break times between sessions. Continue the discussion by requesting meetings from others in the SwapCard platform. Schedule a meeting with another attendee or a sponsor by visiting their page. The panelists and speakers will be addressing your questions live during the stream. During the stream, use the question tab to ask your questions early in the presentation. Go to the poll tab to answer polls that will be discussed during the live stream. If you need help navigating SwapCard, please reach out to our team by mentioning @Parks Associates in the chat box or by contacting one of our team members via our company page. Hello, we're excited to welcome you to Parks Associates' 8th Annual Connected Health Summit, being hosted virtually across 2021 with sessions featuring our esteemed analyst team sharing Parks Associates' latest consumer data and market insights. In its 8th year, Connected Health Summit is an executive conference focused on the impact of connected devices and IoT healthcare solutions on consumers at home. The past 18 months have had an unprecedented impact on healthcare worldwide. The COVID-19 outbreak and resulting public safety measures led to sharp decreases in in-person visits, the delay of many elective procedures, and dramatic changes in how healthcare is accessed by patients and delivered by providers. This year's event, Connected Health Summit, Consumer Engagement and Innovation, addresses opportunities for new solutions including smart home platforms, telehealth services, voice assistants, and wearables to empower consumers, caregivers, and providers with new insight into patient health. Providers must rise to meet the growing demand for services in independent living, chronic care management, remote access to care, and wellness and fitness. New business models, technologies, and solutions are providing a more consumer-centric experience. Telehealth and independent living solutions are extending healthcare and enabling healthcare delivery to a larger market with a specific impact to elderly, patients with chronic conditions, rural households, and caretakers. We look forward to sharing more of our research across the year and bringing you the industry leaders in the connected health industries. Thank you for joining us today for these sessions.
Good afternoon, everyone, and welcome to today's Connected Health Summit track, looking at interoperability in the world of health data. Give me 1 second to deal with the technical issues. And there we go, already fixed. So yes, if you haven't met me before, I am Kristen Hannock, a senior analyst here at Parks. I lead our research in connected health, designing and authoring our research projects, moderating and presenting at our events like this one, and regularly speaking with industry executives to help answer some of the biggest questions impacting the health space today. Before we get started, I'd like to give a special thank you to our sponsors Alarm.com, Everrise, and Essence for helping to make this event possible, as well as to our supporters, CEDIA, Connected Design, DealerScope, SCTE, the Monitoring Association, Z-Wave Alliance, Broadband Communities Magazine, ESA, Health Tech Insider, and mHealth Times. If this is your first time joining us in 2021, welcome. If you were here with us for our earlier events in the year, welcome back. As a reminder, if you are registered as an attendee for our Connected Health Summit, you do have access to all of the recordings from our earlier events across 2021. And also, we're hoping that you join us for our next track of events in 2022. Alongside our virtual sessions on health at home, telehealth and RPM, and seniors and family caregivers, we are planning on resuming our in-person event for September. In terms of the agenda for today's event, I will be kicking things off with a brief presentation on some of Parks Associates' consumer survey data, presenting a look at some of the dramatic changes we're seeing on the health devices side of things. This is data that we've captured in our study earlier this year, as well as some of our prior studies going back to 2013. So providing something of a longitudinal view of how the market has changed and evolved. Afterwards, we will be joined for a visionary insight by Dr. Miki Tripathi, who serves as the National Coordinator for Health Information Technology at the U.S. Department of Health and Human Services. Dr. Tripathi has over 20 years' experience across the health IT landscape, including with industry collaborations in nonprofits such as the Argonaut Project, HL7, the Sequoia Project, the Commonwealth Health Alliance, among others. He will be taking time to answer audience questions, so remember to get them in early. As a reminder, you can get to those through the box on the right of your screen. Following Dr. Tripathi, our own Vice President Jennifer Kent will be doing an executive Q&A with Curtis Sherbo, Vice President of Product at Athena Health. Athena Health provides open connected ecosystems to partner hospitals and medical organizations across the US. Afterwards, we will have our panel discussion on the subject of digitization of healthcare and the role of integration and interoperability in redefining the experiences. We have a great lineup of panelists, including Artie Arenpour, CEO and co-founder of Seekster, Simona Karina, analyst and SME on interoperability with UC San Francisco, Nick Knowlton, VP of Strategic Initiatives at ResMed, Michael Skeff, Chief Information Officer at the Jewish Senior Living Group, and Nico Skivoski, co-founder and president of Redox. Finally, we will end our day in networking discussions in a breakout room. So please make sure to stick around for that. So yes, I'm going to be taking the next 10 minutes or so to do a quick presentation on some of Parks Associates' consumer survey data on the connected health market, specifically looking at the health devices side of things. Again, this is data that we've captured in our annual health studies going all the way back to 2013. Since 2013, we have seen adoption of connected health products more than double among US broadband households. Connected health is now the norm for US consumers, US patients. Over half of US broadband households own and use at least one tested connected health product. The pandemic in particular has had a big impact on adoption of these products among Americans. The average number of devices in consumers' households has in fact doubled since the start of the pandemic, with connected health households now owning a mean average of 4 devices. Looking at the specific types of devices in consumers' homes, we see that wearables is the clear category leader. Within the wearables market, smartwatches are in fact the #1 connected health product overall. The connected fitness category has also achieved high adoption, with a large percentage of consumers focusing in on their wellness and fitness in the past 24 months. One category of particular interest to this audience is connected medical devices. This category of devices has been adopted by around a quarter of US consumers overall, a 10 percentage point increase since last year alone. Many consumers now own and use FDA-cleared medical products, such as smart thermometers from Kinsa, connected blood pressure cuffs from Omron, pulse oximeters, connected glucometers, and a wide assortment of other devices. This is actually the fastest growing category in connected health today. The wearables and connected medical devices in people's homes are generally consumer brands acquired at retail, either in-person retail or now more commonly through e-commerce channels. These are not generally devices that are provided by a care provider or by a hospital. Instead, they are chosen by consumers and paid for out of pocket. So who are the people who are acquiring these products, oftentimes at their own expense? They are largely millennials. Most are parents. They live in higher income households and are more likely to have chronic health conditions than other consumers. Diabetes, either type 1 or type 2, is particularly common among this group. Smartwatch adoption is also very high in this segment. Half of these connected medical device households own and use smartwatches such as the Apple Watch or Samsung Galaxy Watch or others. They are also telehealth users. Over 80% report using telehealth in the past year alone. These are consumers who are at the heart of the economy, patients who are engaged with their health and well-being. These patients also want to be able to integrate all of this data together, to view it in one place, and to have it be holistically interpreted in a big picture view of their health. We at Parks have the data to back that up. In our consumer surveys, we found that patients and consumers overall are highly interested in sharing their health data with their care providers. We asked heads of US broadband households to rate on a 7-point scale how appealing it was to share data, testing 3 different models, and found that 45% of heads of households found at least one model we tested to be very appealing, rating it a 6 to 7 on that 7-point scale. When we looked at telehealth users as a whole, the percent who found data sharing to be appealing rose to 58%. And looking at connected health device owners in particular, we see that 61% are very interested. So certainly this is something that consumers see the value in and the need for. I should mention that this isn't just interest in sharing data from their own devices, although consumers are certainly interested in that as well. Our survey respondents were just as interested in sharing data through devices provided to them by their care providers, so a more traditional approach to RPM. But what impact does this actually have on their behavior and on the medical industry as a whole? Well, it turns out that consumers are now willing to pick and choose their care providers based on their ability to share health data with them. In fact, a full half of our survey respondents said that they are more likely to choose a care provider if they are able to share data with health devices or apps with them. This is higher among those who have used telehealth in the past 12 months, as well as among connected health device owners. 2/3 of these consumers say that being able to share data from devices or apps will impact their choice of care provider. So this will certainly be a key differentiator for providers in the future, as well as ultimately an opportunity for providers to begin implementing RPM at scale and shift their businesses away from fee-for-service and to more at-risk models. Something that we used to talk about at our prior Parks events pre-pandemic was the consumerization of healthcare, making healthcare more consumer-friendly and consumer-focused instead of revolving around the care facility. In the last few years, with the boom in telehealth, consumerization has taken off. People are more able to easily access care in the comfort of their own homes, as well as the safety of their own homes, almost on demand in some cases. Beyond telehealth, we're seeing and hearing that a lot of companies are moving into the RPM space. This includes security players, many of which have the infrastructure in place to funnel data and handle emergency situations, and are already experts at working with peripherals. Traditional connected health players who are expanding their APIs and platforms to meet the needs of care provider partners, as well as players on the data side who want to be able to collect reliable and accurate data from whatever devices are available. RPM deployments began picking up steam in 2020, accelerating into 2021, and are set to further accelerate into 2022. Healthcare is moving into the home. This is going to, of course, increase fragmentation in the healthcare space. More data is going into more places, and there will be more patient-facing players in this space than ever before. Interoperability in this new world is not just about getting device data all in one spot. It's the ability to support multi-vendor environments, making sure that EHRs are integrated with all these platforms, and that data is not siloed. In summation, connected health is now mainstream. Most US consumers own and use these connected health products, and most households who own one own many. These device owners are also going to want to share their health data with their care providers, either through the devices they already own and use in their own homes, or through devices provided by their care provider, or even specially purchased at retail. The ability for care providers to take in this data and use it in intelligent ways will increasingly be a competitive factor in the healthcare industry, both today and especially in the future. However, we do still see challenges. Many times data is still effectively siloed, and integration and interoperability quite often still take a lot of work and a lot of money, sometimes more than companies can afford. There's also the fact that care providers are in the business of providing care, not building technology platforms. The vast majority are not equipped to drink directly from the fire hose, and most need third-party solutions providers to take that data and interpret it for them in ways that they can use that actually improve care outcomes. And with all that's been going on, the new digitization of healthcare, the telehealth boom, the push to RPM, and so many patients becoming much more active in managing their own health, there is a great need to determine new best practices. How do care providers and others use this new data meaningfully? How should these new systems be designed? And even to how do care providers work with these new vendors? These are some of the questions we're hoping on diving into today. And with that, it is my pleasure to introduce Dr. Miki Tripathi, National Coordinator for Health IT with the U.S. Department of Health and Human Services. Again, Dr. Tripathi has over 20 years of experience across the health IT landscape, including with industry collaborations and nonprofits such as the Argonaut Project, HL7, Sequoia Project, Commonwealth Health Alliance, among others. So certainly a great view of what's going on in this space. Dr. Tripathi?
Great. Hi, Kristen. Nice to see you. Can you hear me okay?
Yes, I can hear you great.
Excellent. Thank you. I'm delighted to be here, and let me just talk for a few minutes about really building on everything that Kristen was just talking about the opportunities here and the sort of the new horizons that we're seeing with respect to healthcare delivery, direct patient participation in that, and how we think about that as an ecosystem, from an ecosystem perspective going forward. So for those who aren't familiar with ONC, the National Coordinator, the Office of the National Coordinator, we are responsible for coordination of health IT activities across the federal government, as well as between the federal government and the market. So we do a lot behind the federal wall, as it were, to help with alignment of federal agency activities as it relates to interoperability standards and in general health IT activities. And then we also do a lot out in the market, with respect to certification of electronic health record systems and with standards. There's certainly a lot of ground we could cover, and I'm happy to dive down into whatever is of interest to all of you during the Q&A. What I thought I would touch on in the 10 minutes I think that I have here for formal remarks is related to the 21st Century Cures Act, and in particular, what we're trying to do from the 21st Century Cures Act to move us toward more of a sort of a platform-based approach to interoperability and to access to information, which I think again is very much complementary with all the things that Kristen was just talking about in terms of sort of new technologies and the kinds of capabilities that that patients increasingly have at their disposal and want to be able to be actively part of the way they think about their care and the way their providers think about their care. So the 21st Century Cures Act was passed in 2016. Long time ago, coming on 5 years. It was signed by President Obama, had very strong bipartisan support across both chambers of Congress. And there were a number of things in that, that covered, all dimensions of the Department of Health and Human Services. But the things from the National Coordinator's Office that were, particularly specific to our activities are, one is the requirement or the prohibition for what the law specified as information blocking. And the idea of information blocking is that there is in a HIPAA-based world of making information available, both to other HIPAA-regulated entities as well as the patient's right of access, that is very much a permission-based world, meaning that certainly for exchange among authorized parties for treatment, payment, or operations, as many of you may know, consent isn't required between those authorized parties for the sharing of information. And then, of course, patients have always had a right of access to their information. But there's considerable friction in those types of exchanges, in part because, as it relates to the holders of clinical information, with sharing information with other authorized parties that may not be the patient. There, was certainly a sort of an observation in the market that HIPAA says that people are allowed to share the information under a certain set of circumstances, namely TPO, but they're not required to or obligated to. And so that meant that a lot of information still may not have been flowing because they're not obligated to, they're just allowed to. And then they would decide, whether they were going to or not. What 21st Century Cures Act does, and then of course there was also friction with respect to patients being able to have, I would call it more modern access to their information. And HIPAA, of course, has the right of access, has certain requirements related to how patients can be able to access that information. But it didn't really speak directly to, sort of the modern world of electronic availability of information. And so, 21st Century Cures Act, kind of bridges that gap as well by specifying that patients, as well as authorized parties, but patients should have access to their information via an API without special effort and to all of their information. So the law specifically said those three things. And I think, as many of you may know, if you're developers or close to developers, every one of those terms is very complex and very, very loaded. So when we say that it's without special effort, that it's an API, and that it's all information, each one of those has a lot of complexity associated with it. But those are the very specific things that the law specified. So what ONC has done to implement that law is, what the law specified is that providers certified technology developers and health information networks, including health information exchanges, were prohibited from interfering, was the term that was used, with the availability of that information to other authorized parties, including patients, except under a set of exceptions or unique circumstances. And they directed ONC to define what information blocking is and to define what might be allowable exceptions. So that's what we've done. So the rule that went into effect on April 5th of this year is the applicability rule. It requires that all of those actors now be compliant with with the law. And in particular, it defines the policy for what would be allowable exceptions, with the expectation that an organization's instinct now has to be to make the information available to other authorized parties and to patients. And that under unique circumstances, the ability to have the flexibility to not share information under a set of exceptions that are defined in the rule. But again, the expectation is that the default mode now is to share the information. It's not to not share the information. Again, with the appropriate vetting about the appropriateness of the other party. So, that's a dramatic change, and that's a paradigm shifting change that opens up more information. And in particular, I think what it does with respect to patients and the development of an app ecosystem that can hopefully help patients be much more sort of direct participants in their care, should they choose to be, is that the ONC rules require a set of things. One is the law specifies this change in attitude about the sharing of information and that being the default, as I said. In particular, what the ONC rules specify are that that as of April 5th and up until October of next year, providers are required to, and this is a broad definition of providers. I should also point out that the law is specific, that it says that the law is, the providers are not just hospitals, not just ambulatory providers, but it includes laboratories, it includes pharmacies, it includes physical therapists, it includes dentists. And again, that's defined in the law. That's not defined by ONC. So the law is very expansive when it talks about providers, and it's not just providers using electronic health record systems or certified electronic health record systems. It really applies, to that very broad definition. So now getting back to the ONC requirements here, the requirements are between April 5th of this year through October 5th of next year, of 2022, so less than a year away now, what they are required to make available. So, the question of information blocking, first question that one ought to ask is, what information am I required to make available? Because I got a lot of information here. So between now and October 5th, the minimum requirement is what's called the US CDI, the US Core Data for Interoperability. It's something like 25 data classes and elements that are defined by ONC as a standard and that are required to be supported by electronic health record vendors today. We started with that because we wanted to give a glide path to the industry, recognizing that this is a real paradigm shift and is a real sort of a change that they need to make in sort of the way their systems are configured, as well as the way that users interact with those systems and think about their compliance policies. So we started off with what we know they're able to do today, which is the US CDI. But starting on October 6th of next year, they need to expand the information that's available to what's called EHI, electronic health information. Well, it's all called electronic health information, but what they're required to do is expand that to basically be all electronic information available that's in their system, whether it's structured or not. And and the requirement there is, again, starting October 6th, that's required to be made available to other authorized parties. And what that means is that we're now going to, we'll start to see the availability of not just the structured data elements, but clinical notes and other types of text narratives that are buried in those EHR systems that up until now haven't been readily available. And and for a long time, frankly, it wasn't clear that that was really an issue because for a lot of that information, because it's so highly unstructured and is narrative in nature, there wasn't a whole lot that that could be done with those, aside from that couldn't be done with that couldn't be done with a fax being sent to another provider for a human readable type of interaction. But as we know, technology has advanced. The availability of high computational resources at commodity prices has advanced, and the technology for algorithms and AI and ML has advanced to the point that I think that we have a lot of reasonable expectation that the availability of that information will develop and be opportunities for innovation and a whole sort of cast of new entrants and other entrants, existing entrants, to start to think about the ways of taking that unstructured data and making it useful for patient purposes themselves, as well as for the broader population health management and direct treatment of patients in much more valuable ways than we're able to do today. So that's all what's coming here. That we've got the requirement for the U.S. core data for interoperability that's required to be made available. The broadening of that to all electronic information starting on October 6th of 2022. And last thing I'm going to mention is that by the end of 2022, all certified electronic health record systems, which is almost every electronic health record system that you can name, all of them are required by the end of 2022 to support a standard FHIR-based API for the availability of that US CDI information. Right now, for all of the great adoption and the great sort of advances we've had in the adoption of FHIR, which is still a very new standard, but we've seen a lot of industry advancement. There hasn't been a requirement for anyone to implement FHIR in regulation. That's all been on the payer side. That is a requirement for the CMS interoperability rule, but from the clinical side, there hasn't been a requirement. There is a requirement to implement an API, but it never said a FHIR API. And that's been a point of friction for developers, because they still have to contend with the fact that, on the one hand, there's an API now, so they can start to build solutions that can access that information, but it's still proprietary APIs, still varies from vendor to vendor. So scalability is an issue, and the economics become a little bit more difficult. Started by the end of next year, every vendor is required to support a particular implementation, a particular specification, a technical specification that ONC points to for an open industry standard API. And we believe that that is then going to be, sort of the fertile ground for a lot of developers to be able to come in and now see the economics and the scalability across platforms to move us to more of a platform-based approach to access of information, where you've got the core systems, obviously, that'll always have their functionality, but the opportunity now for lightweight apps and other more focused apps to be able to develop specific applications, accessing very particular types of data to serve very specific needs as they think about, sort of their patients and their customer base, and how they want to be able to develop, sort of value-added solutions on top of the EHR systems that exist today. So there's a lot more I could cover here, but I wanted to, make sure that that we had a good sort of grounding in ONC's attitude toward what we'd like to be able to see the 21st Century Cures Act help to bring us toward, and what's going to be happening over 2022, because that's going to be a huge year for for all of the various things that I talked about.
Yeah, so certainly a lot of very exciting movement in terms of this type of interoperability, making sure that the EHR systems can actually better talk to each other, get the data out there, and patients actually have access to this as well. So we do have some questions in from the audience. Looks like they're very excited and learning more about this. Our first question, Anne, is asking what is the kind of the biggest challenge for creating policies around interoperability. I know from what I've heard from a lot of different EHR providers that the data can be very differently structured with different care providers, and making sure everything actually talks to each other is just historically been an enormous challenge.
Yeah, I mean, certainly, I think that the biggest challenge in health IT in general, and it's certainly true with everything, the very specific things that we're working on, and I would say in healthcare at large, when you think about the U.S. healthcare compared to other countries, and is that our biggest challenge is the fragmentation of the market, both on the supply side and the demand side. And and that creates a lot of challenge, because you've got a lot of competitive pressures by all the various actors that are competing with each other, and you have the great difficulty of having the market develop its own coordination mechanisms to get scalable approaches to things. Where if you think about other industries, whether it's retail, you think about financial industry, you think about airlines. There was enough concentration in some of those markets, either on the supply side or the demand side, where the market itself could get together and say, you know what, we're going to create a set of standards that all of us are going to agree to and move forward. In healthcare, it really relies on the government actually to step in to try to help provide that coordination where the market can't on its own. So that's one big challenge, and why ONC is trying to judiciously step into these things. I mean, I've been in health IT for 20 years, all the private side, the nonprofit and the for-profit. So I very much, sort of appreciate that, government can screw things up, but I also appreciate that government can actually help move us forward as an industry, and that judicious application of, everyone wants regulation, but just the right amount of regulation. So, that's a big part of it. The other thing I'll just point to, since we're talking about consumer apps, is privacy and the lack in the US of a general privacy policy outside of HIPAA. And as we have more and more, developers and entrants into the market who aren't covered by HIPAA, I think that poses a challenge for all of us, in terms of, what rules do they live by? And, how do we assure that individuals know what they're getting into when they have their information made available to, to apps or, other types of solutions that live outside of HIPAA, and then perhaps have lots of, unintended consequences if that information is shared in ways that the individual doesn't fully understand.
Yes, I know I've certainly heard different companies acting on a global scale are certainly expecting more and more privacy regulations to come into play, potentially looking at GDPR in the EU as maybe an example of what might be happening around the world in the next few years, just given all this very rapid adoption of health technology. So something that you touched upon that I thought was very interesting was talking about the ability for an individual patient to be able to access their complete medical records. So of course, right now, we don't really have a centralized system for these records in the United States. There was talk a while ago about creating these types of personal health records with maybe the tech giants trying to get involved. And of course, that raises its own challenges. With so many people nowadays not even having a primary care provider, what do you expect this to eventually end up looking like once this all gets off the ground?
Yeah, I think so. So I guess the first thing I would say is that it already is off the ground, meaning that, we've got this foundation of electronic health records already. We've got the requirements for that U.S. Core Data for Interoperability, U.S. CDI, is required to be made available through those EHR systems to, to patients. Whether patients choose to access that information is a separate question, but it's required to be made available for those who want to. And of course, in the pandemic, we saw a huge uptick in patients all of a sudden wanting to be able to have access to their patient portal, for example, which is great. And there is also a requirement that they have that information available via an API, but that's a functional requirement, not a technical requirement. So all of that is out there. And when you think about, the Apple Health Record, for example, and and what the ability on your iPhone to be able to download your record onto your iPhone, and there's a common health application that's for Android, which is a parallel solution that Samsung and other phone companies have picked up. Both of those actually were created because of the regulations that provided the uniformity of availability of that information through APIs from those EHR systems, and that only came from regulation. Before that, they didn't have the ability to scale their solutions in a way that allowed them to have access to that information. So that's the first thing is that we've already launched, but in terms of where does this go going forward? I think there's multiple levels. One level is certainly the ability of individuals to be able to get better and better and more seamless access through the device of their choice, whether it's their phone or whatever it is, through that standard API, and they can do that directly. They can do that through, another vendor. There are, increasingly, vendors that offer patient-facing solutions, and then authorize those solutions to be able to go and get the information on their behalf using OAuth and very, industry standard mechanisms. Just in the same way that you get access to HBO through your Verizon Fios subscription, doing it that exact same way to be able to say, I'm going to authorize this vendor to go and get my information from all these other places, and then be able to sort of collect that information. So I think that's going to be one level that will certainly be there. I think one of the challenges that you may be alluding to here is we don't really know what consumers want at the end of the day, because it's a very heterogeneous market. And of course, it's very dynamic, meaning that consumers' preferences change depending on whether they have a condition or not. So I have the good fortune right now, at this particular point in time, of being healthy. If tomorrow I got some chronic condition, diabetes or whatever it is, adult onset of diabetes or something like that, my attitude toward all of this might change dramatically. As you pointed out, I think in the previous presentation, diabetics are very active in thinking about technologies that allow them to have better remote access to think more about being able to aggregate their information and use it for those other purposes. So I think that's a little bit of the challenge, is that some consumers may have no interest at all in being able to in being at the center of their information. Others may be very actively engaged in wanting to do that. What we want to be able to do from an ONC perspective and a federal government perspective is say, we just want the access and the availability for any individual who wants to do that. And we want the ability for an ecosystem to develop on top of that to provide value-added services to those patients who want to be able to access their own information and do a variety of things with it.
Mm-hmm. So certainly some very exciting moving forward. So we have a few more questions in from the audience. One of them is asking if you can talk maybe at a high level on some of the defined exceptions with regards to the data sharing.
Sure, there are 8 exceptions that are on our website. So very easy to find on our website. If you go to healthit.gov, you'll see them there. But some of those exceptions are just to tick off a couple. There's one is a harm exception, which is if the provider believes that releasing the information would cause physical harm to a patient, which is a HIPAA construct that comes right from HIPAA. And what we're doing is saying, well, that also applies here. That if a provider, for example, feels that it might cause harm to an individual, then they don't have to release the information. There is an exception related to infeasibility, meaning that the information has been requested, but in a way that I actually can't provide the information in the manner that the requester asked for. So we don't want to get into a situation where a provider is being asked to make information available in this particular format and they're in this particular way, and the provider literally has no ability to do that. So as I mentioned, the rule covers more providers than are required to use certified health IT systems. So you may have many providers, physical therapists, who aren't even using an AHR, or who have a rudimentary kind of system. It isn't like an Epic or a Cerner or an Allscripts or something like that. And someone asks, to have their information available in a FHIR API. Well, they could very reasonably say, that's infeasible. I can't do that. I can do it in other ways, but I can't do it in that. So that would be a couple of examples of the kinds of exceptions that we allow.
So I have another question in talking about some of the challenges of working with very, very unstructured data, and how exactly, what solutions are there in place to be able to actually share this in a meaningful way without introducing all sorts of complications.
Oh, there's always going to be complications. I can't get rid of those. And there's an old adage that you can never get rid of complexity. You can only move it around. And so I think in this case, what we're hoping for, and what we fully expect, is that by making that information available, let me just step back for a second. One of the things that we've done as an industry for about a decade, maybe a little bit less than that, since EHRs haven't been around for that long, across the market, is that we've kind of tied interoperability, or the pace of interoperability growth, to standardized data, because we've always said, well, you want the data to be able to be standardized so that it can be aggregated from multiple sources, and then you can apply all sorts of analytics and all sorts of tools to it in as seamless a way as possible. That conceptually makes a lot of sense, but one of the challenges with that you start to confront is that, well, that means that your pace of growth of interoperability in terms of the scope of it is determined by the standardization process. And standards organizations move at a very deliberate path that isn't really at the speed of the internet, let's just say, and certainly not at the speed of innovation and business innovation. So one of the things that we're doing here is we're saying we're going to take a philosophically different approach to this, which is to say, let's keep the floor rising in terms of the standardized data that we're making available, and that's that US CDI that I talk about. So every year we add more data elements to the US CDI, and we push the industry to standardize more and more data that we think is important to the public, is important to industry, and important to patients. And so that continues. What we're saying is all that information on top, free it, make it available, let the consumer of the information figure out how they're going to make more sense of it. And as I said, there are already lots of, sort of commoditized type of tools. So when you think of the AI ML solutions, the large platform vendors, offer a ton of tools that are built into their platforms to do this, to do natural language processing and other kinds of things. And there are a ton of startup vendors that also are doing a ton with algorithms and AI ML. So we think that there's a lot of opportunity there to, make real advances with more availability of that information. And one of the things that we have done in the rule is we've said that there is no expectation that you standardize that information. However, there are two requirements on the availability of that information. One is it has to be made available in what we call a machine readable format. So, we don't say that it has to be in CCDA or FHIR with sources and mapped to the USCDI or whatever it is. But we do say it has to be in a machine readable format. It can't be a JPEG file, but it can be a CSV file. It can be an ASCII file. It can be a structured PDF that has structured data embedded in it. So that allows the opportunity for me using my own system to be able to take that information as structured information and then apply AI and ML and any other kind of logic to it to be able to make sense of it. So that's the first requirement that we had, is we said it has to be machine readable format. And then the second is we said you also have to provide in a public API, in a public URL, the export format and schema for the information that you're making available. So, you don't have to give up your proprietary schema. If you want to have a different, more, sort of watered down schema that you make available for that export, that's fine. That's up to you. No one is asking you to give up your intellectual property. But the important thing is that the consumer of the information needs to be able to make sense of what's in that file that you have exported.
So certainly a lot of improvement over where we are today.
I think so. I hope so. And what we want to be able to do is sort of unlock innovation here and say that that let's let the innovative community and the hive mind sort of attack this problem and help us advance progress.
It looks like we have time for one more question from the audience. So given all of this expected interoperability progress in 2022, 2023, it looks like it could really be a major year of innovation from developers. So how will an average patient actually notice these changes?
Yeah, that's a great question. So I think I think what we'll start to see is and I'm hoping what we'll start to see is is more solutions out there that are directed at at the patient use case and that start to have the more refined kind of segmentation of use cases that you see in more mature markets when you think about consumer products and how refined that segmentation is to the very specific needs of different market segments. Right now, frankly, most of the solutions that are out there are about, here, you can download your data into this solution, and then that's a dead end. It's like, well, great, now I have my solution on my phone, my data on my phone. What have I accomplished except that now it's actually not protected by HIPAA, so I've actually taken on more risk, and I'm not getting a lot of benefit. But the availability of having this sort of more platform orientation of the of these clinical source systems and the standardized APIs across them, I think will create the opportunity for more market entrants to start to develop more scalable solutions, and the economics start working better for the innovation community to be able to come in and say, I want to develop these more refined products now that are going to scale across all of these for that diabetic patient who has very specific needs, perhaps other comorbidities that they want to be able to sort of manage in a tighter way, for the asthma patient who has specific needs, for the the patient who is basically well and fit but has other kinds of needs that they want to be able to do a little bit more of daily monitoring and in the measured self kind of approach. All of those segments, I think, will be able to be sort of addressed with a more mature ability to be able to have access to that information in more scalable ways. That's sort of the fundamental of being able to start to develop a mature market around these things. So I think that hopefully what we'll start to see is that patients start to see that there are more apps available to them that serve their particular needs. And that's going to take a couple of years, right? I mean, I think what this is saying is that in 2022, a lot of that, the platform is now there for them to do that, and we want the market to be able to respond to that. I will say one big question again for all of us that we'll just start to see is how many patients really care and how many patients want to do that. It may be that the vast majority of people don't know because they don't really care and they don't want to. I think we also do need to face the question of, well, very often people don't know that they want something because they haven't been able to envision it, right? The famous Steve Jobs thing. Individuals don't know what they want because they can't actually envision it. But once you show it to them, then there's high demand for it. So so I think that'll be a part of sort of our collective learning here going forward.
Yes, so certainly there has also been just a great deal of changes in the past few years in terms of the regulatory environment, in terms of reimbursement models that have allowed a lot of these new innovative things to really take off. So we're seeing the birth of virtual primary care services. We're seeing a lot of care providers begin to actually implement RPM at scale in the different patient populations. And of course, this massive movement in telehealth as well. So it certainly seems like a great deal of opportunity in terms of driving forward some of these new types of solutions.
Yeah, I think so too. And I hope that we start to see advances, and maybe this is where patients will really notice it. Is not in the clinical information and that kind of solution that deals with sort of very advanced or very specific things related to their condition, but more practical day-to-day customer service level things that that people struggle with in healthcare that that they don't struggle with when they go to Lowe's or CVS. So the ability and of course some of the Medicare Advantage plans and some of the other new entrants to the market that are directly attacking this. But how do I provide just a better customer experience? How can I sort of track my prior auth requirement? Hey, how do I know there's a prior auth? And then how do I track where that is? Oh, that went to the payer. Oh, it's going to be back in a day. Oh, okay, now I know that it's approved and I can contact that orthopedist. Whatever it is, how do I have that better customer experience through better interoperability? Through these solutions and the access to the clinical information. CMS interoperability rule requires that they have access to the claims information as well. So I think we'll start to see solutions start to bring that together and that hopefully translate into things that are much more about better customer service overall, because that's what all individuals care about, regardless of whether you're sick or not sick. You care about that basic customer service, which we don't get today in healthcare.
Yes, it's certainly, again, another major improvement on that front as well. Thank you so much, Dr. Bothy, for joining us today for our Connected Health Summit event. Very happy to hear from you and some very great news in terms of what ONC is doing.
Great. No, thank you. I really enjoyed being here, and thank you for the invitation. And please reach out if we can help with anything, or you have questions or concerns or things that we can help with. We are your national coordinator too. So please use the opportunity to reach out to us. Thank you.
Absolutely, and thank you so much.
Okay. Bye-bye.
Yes, thanks everyone for joining us for this executive keynote. Next up, it is my pleasure to introduce Jennifer Kent, our VP of Research here at Parks Associates, who is going to be doing the executive spotlight with Curtis Sherbo of Athena Health. Jennifer.
Great. Thank you, Kristen. And thank you, Dr. Tripathi, for that great kickoff session and really setting the context and the vision for our discussion today on the interoperability of data in healthcare. I'm so pleased to be introducing and welcoming to the executive spotlight, Curtis Sherbo, who's the Vice President of Product Management at Athena Health. He's been with Athena Health for over 4 years now, working on a team that delivers a lot of the product feature sets for their patient portal and other efforts to enhance the really modern user experience with health records and health solutions. So, Curtis, we're so pleased to have you with us today.
Thank you. I'm really excited to be here and share what we're doing here at Athena Health and to make patient lives better.
Awesome. Well, before we get going, why don't you tell us a little bit more about Athena Health for those who might come from a different part of the ecosystem and might not be fully aware of what you do and also your role there.
Certainly. So Athena Health partners with healthcare organizations across the care continuum to deliver clinical and financial results. We really achieve this through a suite of services and products in the areas of revenue cycle management, electronic health records, and of course, patient engagement. My particular role as a product management leader is to lead our patient experience subdivision, where we really tackle all of the challenges of engaging patients and delivering the information they need and supporting our providers in interacting with patients.
So everything that Dr. Tripathi was just talking about, I imagine you've been kind of living and breathing for the past 4+ years, right? Can you share a little bit about Athena Health's vision of data interoperability, right? What do you think about? What do you plan for? When you're thinking about making this experience and making the data flows work, right, for the user.
So certainly I work really closely with my colleagues and thinking of the different aspects of the data. But my particular focus is really, again, on the patient side. So I really like to think about how do I make the data more accessible to patients? So how do I bring that data forward, bring it front and central into the interfaces and experiences that they're looking for? And then how do I bring data from multiple sources together? So I'm really looking for interoperability to bring data from multiple providers, multiple experiences and multiple opportunities together into a single experience. So I really want to drive, kind of that single patient experience as much as I can to let that patient view everything in context and as related to each other. One of the challenges is the material is often quite complicated, or it's in jargon. We're starting to expose more of the details of the visit, and it's not easily understandable by the patient. And what we want to do is try to give them some more contextual support and really kind of drive more information, supporting information into that experience so they understand what they're looking at. Because it's one thing to provide that information, but patients really need to understand it.
Can you tell me a little bit more about how you do that, right? So, if I'm exposed for the first time, very exciting, I get to see a doctor's note, some unstructured data, some notes go along and I say, I don't think I really understand that. So, how do you really practically put that in practice that gives me a little bit more indication of what this might mean?
Certainly, I want to try to, expose the raw data, but also try to interpret some of the data. So whether there's be a diagnosis or a medication that's prescribed or a test result, there's libraries of information available that we can try to surface contextually, as a patient. So a patient doesn't have to turn and go to Google and Google what something means to understand. They're actually going to have right in that experience an explanation of what something is. So whether it be a test result, what's the normal range, we don't want to provide too much guidance, but we want to understand what is that test result measuring versus, a diagnosis that what is that condition, some more background information. So that's what I'm really trying to drive in that experience is stop having to force the patient out of the experience somewhere else to go, to an untrusted source, because we put a little bit too much faith in Google rather than, from your healthcare provider.
Yeah, absolutely. That makes sense. Now, it was just mentioned in the last discussion, of course, how the pandemic and consumers' experience over the past, 18 months, 2 years has really driven much more engagement with the patient portal, probably than ever before, raised base familiarity that patient portals are out there and what you can kind of engage with. From your perspective of let's say the data that you see, have you been either surprised by the engagement or surprised by different parts of the portal that users seem to gravitate towards or what they're missing? Anything you can share about sort of the patient portal engagement over the past couple of years?
So I don't know if I'd characterize it as surprise, but more accelerated. So definitely we were really investing in trying to improve access to information beyond the requirements, the regulatory requirements, but try to put the patient first, and patients are seeking more information. And so we were trying to create really first-class experiences that try to challenge things that are available out there in the consumer world. The pandemic really drove rapid adoption of all of these services. And so bringing in things such as telehealth, bringing in, more awareness of the patient portal, driving higher utilizations of patient self-check-in services, so digital check-in, really has brought all of those things forward. I think probably the areas I see the most engagement in the patient portal is really around the test results, especially when, we're providing a lot more proactive testing, especially around COVID-19, and people are seeking those results more proactively and more rapidly. So being able to provide that information in a timely fashion and as accurately as possible, that has really a risen use case, I think, from a patient perspective.
Yeah, definitely. Now, when you think about maybe the original creation of EHRs, right, and the purpose of that, and who that sort of the end user for those types of systems are, it's really providers and billing, right, the payers, right, making sure that things can be recorded in a way that reimbursement happens properly. Today, do you feel like all of the different stakeholders around, if you take it as a patient-centered experience, that need access to the varieties of health data out there can get it? So you've got the patient, the provider, the health system, the payer for sure, but then also family caregivers, home health organizations, right? Maybe device manufacturers who need to see performance of their device data, that may or may not go through the EHR, of course. But right, can you talk us through who you think is being served really well, and maybe where more development still needs to happen to really serve well everybody kind of around a patient experience?
That's a great question. So it's definitely a challenge as we look at the vast amounts of data we've now been able to collect in electronic health records, and obviously the first purpose of that collection of that data was to serve as the documentation for the provider, and then support, like as you described, the supporting information for payers. But now as we look to enrich that information with notes from other providers and bringing more data from different organizations together, we start to face a real challenge of too much data, or there's just, or I wouldn't call it noise, but there's a lot of information, and being able to process and understand and make use of that information is really challenging. So if I were to look across the spectrum of all the different players as you described, I don't know if anybody is particularly served well. There's opportunity to serve everyone a whole lot better. But the real, I think, where we can go is improving it for patients and providers by surfacing more relevant information, making all of the information accessible, but surfacing and highlighting the more relevant information for the need at hand. So whether it's at a time of care or a time of visit, or patient looking back in time and wanting to understand some more of their history there as well. But I think as we build that data set, we can look to expand its usage while navigating, obviously, all of the challenges around privacy and security of all that information.
Yep. Now, of course, again, one of the largest changes of the past year and a half or so has been this massive push of care from facility into home, with the expansion of telehealth services, ramp up of remote patient monitoring, hospital at home programs. Has the expansion extension of care into the home further fragmented the data landscape, right? That's something that Dr. Tripathi brought up, that we have a very fragmented ecosystem here, right? So what has this done to data flows and the interoperability push?
I think I don't know if it's like from our perspective, we have taken great pains to try to not let telehealth be delivered differently or supported differently. We're obviously delivering it differently in that it's virtual care, but we've really tried to integrate it into our workflows and make it a really positive experience for the providers so that they can still deliver the same level of care. There's still the gap of some of the personal interaction and some of the vitals collections and things like that you could be doing in an in-person visit. But I think it's more almost in the long term like an expansion of care. We're actually going to have more data rather than less or fragmented data, in that we are achieving more reliability in visits and people receiving care where they might not have been able to receive that care if they had to physically go into the office. So we've definitely tried to prevent that fragmentation and bringing all of that data together. But that along with that, enabling those experiences, there's new challenges in trying to collect some of the same information that you might have gotten in an in-person visit.
Yeah, certainly. You raise a really great question around devices, right? And the fact that kind of we certainly see the lack of that vital sign and device data for most virtual consultations today, is a major gap between what you would experience in the facility. Now, of course, the remote patient monitoring, provision devices, or bring your own device from consumers' perspective. There's definitely, we're seeing major growth in ownership of connected health devices by people at home, right? How do you think about bringing the device data into the EHR, sharing in ways that are helpful and maybe not data overload?
So I think this is going to evolve in stages with a real focus perhaps on the chronic care management use cases to begin with, where there's really an ongoing health concern and we really need to monitor a patient's condition and get that information back to the provider. And there are some great solutions out there today, some really great medical grade devices that can collect that information. And there's various integrations to try to bring that information back to the provider in a meaningful format. So I think that there's, as a kind of standalone evolution of technology, we're going to get a lot of benefit from those types of things. But with that, there's a lot of cost to administer that, to ship out to devices or train a patient on how to use that equipment. I've heard some stories in talking to providers where they've leveraged a telehealth visit to be able to view the output of a device in the home, where they've had the patient hold up the little LCD screen to the camera so that they could read it to collect that information. So obviously we want to evolve and have those devices be more connected and bring that data right into the chart and into the correct clinical workflow to support the patient. The second kind of evolution of that is as we have more consumer grade devices. We often have viewed these consumer devices as fitness data and fitness information, and we haven't really necessarily wanted to consult or consider that data in the health care context or in the care delivery context. But I think as the quality of those devices and the validity of the data being collected by those devices is proven, we'll see more of those capabilities being brought forward into the care setting as well. And so that's really the expansion of who we're addressing in this market. So we're getting out of the chronic care cases to perhaps the rising risk cases, where we're looking for early warning signs or looking for reasons to support a patient earlier in a diagnosis or a direction that their health is going. And I think as that data becomes more reliable, then we could start to integrate that into our experiences and bring that into our electronic health records. And perhaps that starts out by being viewed on regular visits, well visits and things that data is accessible. There's clearly a risk of generating far too much noise, and we don't want to go pollute the chart with all of that information. We do not want to inundate the provider with all of that information unnecessarily. But we want to start to find the happy medium there, where that information becomes useful and medically relevant, and to provide more context for the provider. And then I think in the final evolution is we will be able to start to build intelligence and with that data, and actually implement machine learning type technologies to start to raise alerts, perhaps if there's anomalies in some of that data over longer time periods and things like that.
Yeah, absolutely. We see that sort of in development in the future as well. I think that you're right that I think people tend to think of the consumer grade devices as mostly fitness devices, but certainly, you can go to Walgreens and CVS today and buy a blood pressure cuff, a weight scale, a thermometer, some really key vital signs that provide in a virtual consultation context very, high quality data that could be looped in today that isn't necessarily steps, right?
Yes, absolutely.
We've gotten a few questions actually on the devices side, so I'd love to go ahead and take those. So one question is, what kind of devices are being used by patients? What rigor is required by device providers to be acceptable in providing data, I guess, back into the EHR is the question here, right? So from a device manufacturer who's listening to this conversation, what sort of effort do you think is expected out of them to make sure that they can be contributing, right? And that their data flows would be accepted and looked at by providers?
So I think there's a lot of rigor and regulation around some of those devices for the high quality, data that they may be generating if they're the healthcare specific devices, and often those are already chosen by the provider themselves that they would like to deploy a monitoring device or monitoring tool to the patient. So perhaps it's a patient who's enrolled in a care plan ongoing, but really, so there's already been some validation or acceptance by the provider that they might deploy that type of device. And then I think the evolution, where there is no standard today around the consumer information, is how do we make that data relevant? And I think there's going to be baby steps over time where we start to just look at the information. I think that there will be more vetting and testing and analysis of the quality of the data coming out of things such as for example, an Apple Watch, which I might characterize as one of the leading devices that is starting to try to get more certifications or recognition as a valid data collection tool.
Yeah, absolutely. A very similar question came in asking, with so many new devices in development and now on market, are FDA approved devices still necessary? And are private payers viewing this issue differently from CMS? Are they pretty well aligned?
So I think that, clearly the FDA approved devices are the preference, I think, from providers' perspective. I think it'll take time for providers to trust other sources of information, but they might be more of a leading indicator, and then they might verify with follow-up with other sources of information, either cause schedule another visit based on some data, or a patient raising their own concerns based on that data that is becoming available. And then I think over time, as providers gain trust in the data coming from those devices, I think we'll see adoption. It's difficult to predict how fast, but looking at the pace of how much digital engagement and how much advancement we've made in the past 18 months, it's been incredible. So I think we're only going to go faster, not slower, going forward.
Yeah, certainly. So just from the provider point of view, we've talked a little bit about patients and patient portals. Are you seeing a demand for certain new features, right? So have providers experienced over the past 18 months or 2 years, or health systems asking for different types of things in their integrations, right? Of what they're looking for out of you and innovation that they want to see?
Certainly. They really want a lot more electronic patient provided information. So not just from devices, but patient reported data, any kind of, beyond the basic, health HPI and ROS type use cases where they were looking for more info, a lot more electronic engagement around patient reported outcomes, and really trying to understand the evolution, post-care and the follow-up kind of scenario. So I've had a lot more requests in those areas, and really digitally activating patients in this way, and just trying to collect more information prior to an encounter or a post-encounter as well.
Yep. Okay. If you have any additional questions to the audience, please submit them. And also there's a polling question in the tab to look at as well for the panel that's about to come up. I see a couple other questions coming in before I get there. I'd love to hear, when you think about moving into 2022, we just heard a lot about some very specific requirements that are coming into place in 2022 in April and October and by the end of the year when it relates to interoperability. Whether it's those or additions, what are your kind of highest priorities in product development here at Athena Health for next year?
So the highest priority is meeting all of those requirements for sure. So
Yeah.
we're definitely have been very proactive in our development planning and execution through 2021 and into 2022 to make sure that we have met not only the spirit and the minimum requirements there, but to try to go beyond and really drive a great patient experience. So really focused on more access to data, faster access to data, and trying to enrich the experiences around that data. So it happens, a lot of the requirements, timing is coinciding with a lot of product improvements that we are making around experiences and making it easier for patients to access their own health information, whether it be easier to log in or launching new interfaces such as native mobile applications for our phones and devices that have really tailored experiences. But bringing all of that highly important information to their fingertips in more formats just to make it more accessible. So we're trying to really go above and beyond that accessibility to really drive a better experience.
Okay, and then so thank you for that. That's we're very much looking forward to all the innovation that's going to be coming and all the certainly the integrations, kind of again through to what the consumer can actually see the progress, right? And it's not a job that we're putting on the user to be able to go find and trace and piece together all the pieces of their health, right? Information. To that point, can you talk a little bit about besides the single patient, right? Often you have an elderly parent, right? Another child, perhaps in the household, spouses, other people in your world that you might have to care for, and how progress you think is being made and being able to incorporate, right, other people's loved ones and care network, right, into their health plan or their health support system, as we know that's really important for outcomes.
I'm really glad you raised this point. This is something that we have tried to kind of bring into our DNA for some time now. We describe it as making room for advocacy. How do we allow others to care for other people beyond the traditional family relationships, the parent-child or type relationships? And so we're really trying to shine a light on all of our features and access in a different way and think through some of those use cases of how we can either share the right amount of information. So balancing granting more access to information with more sensitivity or safety controls around privacy concerns as well. So we're really, this isn't something we have fully solved, but it's something we are very focused on in trying to improve that access and allow a patient to grant access to appropriate parties and really enable them to know what's going on and really support each other. And we think this is something that something we've been thinking about for a long time, but has really been highlighted, obviously, through the pandemic, where there's a lot of more peer-to-peer support and how do we help advocate for each other and really bringing out the humanity of healthcare. I'm so quite excited about that trend and what we can do there. And we're definitely working hard on that.
Well, and related to that, certainly we want to make sure that we also talk about sort of health inequities, right? And especially in the access to health tech, right? And patient portal. So fantastic that there's been more engagement than ever, but is that even across the board? And how do you train folks maybe who need more training, who aren't necessarily tech savvy or don't have reliable connectivity in the home or don't have a mobile device? How are you thinking about those issues?
So definitely we've had some fantastic interactions with some of our customers that serve some of those patient populations and trying to understand better how to provide access. And some of it is just different in different channels. And so patients may not have access to a computer or be able to log into a patient portal. They may not have a suitable mobile device. but there may be other ways to interact with them digitally through more conversational type interactions in a secure fashion, if possible, and or even trying to elevate to telephonic interactions where possible. So we still bring along all of our telephone services and be able to outreach to patients via the phone as well. And it's still going to have a place in the future to help service those markets as well, or those patient populations as we go forward. And then, of course, we'll be looking at additional ways and different methods to try to help patients.
So we just have time for about one more kind of final closing comment. Typically at Parks Associates Connected Health Summit, we have folks from really a very wide variety of backgrounds, right? They may come from payer, provider, health system, also device manufacturer, both on the regulated and on the consumer side, home service providers, right? Everyone trying to figure out how they can best play, in the health IT world. Obviously, you're sitting at a point in the ecosystem where there's a lot of integrations and a lot of partnerships. So what would you say to the variety of audience members we have here and how they should be thinking about interoperability and working with a company like Athena Health?
I guess my advice would be to really think about how do I focus the information, focus the data so that the data that is being interoperable is the right data. And we're not just trying to provide more data. So whatever is actionable, if we think about actionable data that a provider can act on, a patient can act on, or an automation can act on, that's really going to make the difference going forward. And receivers are going to be more interested in that information. So the more that we can make actionable insights available, I think we're really going to drive much better adoption of interoperable data over the long term.
Fantastic. Well, Curtis, thank you so much for your time and for your insights today. Really appreciate joining us.
Great. Thank you so much, Jennifer.
And next, we're going to have Kristen Hannock come back to lead our full panel discussion of our industry experts on healthcare interoperability. Thanks.
As of 2021, almost 25% of U.S. broadband households report either currently caring for an aging loved one or expecting to provide care in the next 5 years. The pandemic has exposed the vulnerability of our senior population, and an increasing number of seniors and caregivers seek solutions that keep them both safe and able to live independently. New tools like video conferencing, grocery delivery, e-commerce, telemedicine, and independent living solutions are available to serve this growing market. Retailers, service providers, and device manufacturers are expanding the market of technology solutions that support independent and safe living for seniors and caretakers. Our latest research, Health and Well at Home, Senior Assistive Technology, quantifies the impact of the COVID-19 crisis on seniors and family caregivers, assessing concerns, pain points, and the demand for technology products and services, including trending data from our past surveys. For more information on this new research, please contact our team at sales@parksassociates.com.
Thank you so much, Jennifer, and welcome back, everyone, for our panel discussion talking about the digitalization of healthcare and how interoperability can help redefine the experience. I am joined today by a really great lineup of panelists that I'm so excited to introduce. So I'm going to go through and introduce these panelists one by one, and they're each going to take a few minutes to talk a little bit about themselves and about their companies as well. So first up is Arti Iranpour, CEO and co-founder of Seekster. Arti, can you tell us a little bit about yourself and what you do there?
Yeah, Kristen, thanks so much for Parks Associates for having me in Seekster on the Connected Health Summit. It's great to be back. Unfortunately, we're all virtual still, but I remember the first one that we did years back at the Pendry Hotel, so it's just nice to be back. I'm Arti Iranpour, CEO of Seekster. Patient-centric data interoperability is healthcare's biggest challenge, and that's why I'm here today. It's been my number one mission at our company. That is why I founded Seekster, a leading healthcare technology company where we have pioneered the ability to break down health data silos at scale. Our enterprise SaaS platforms aggregate disparate health data sources into a single 360 degree view of a patient in real time, which is one of our biggest differentiating factors, solving a multitude of challenges for life sciences, patient engagement, and of course, data interoperability. Our platform is patient-centric, obviously, and we are backed by Takeda, 23andMe investors, as well as United Healthcare Group investors. So we're really excited to be on this amazing panel and learn more from all the other panelists.
I'm very happy to have you here as well, Artie. So next is Simona Carini, an analyst with UC San Francisco. Simona, can you tell us a little bit about yourself and some of the research you've done?
Yes, hi everybody. Again, I'm also grateful for being invited to speak at this panel rich in expertise. My role in working at Dr. Ida Sim's lab at UCSF has been various, but right now, and for the purpose of this panel, the focus on the last few years of our research lab has been on developing data schema definition for semantic interoperability. And my manager, Dr. Ida Sim, is the co-founder of a nonprofit called OpenM Health that has been working for 10 years in this space. And more recently, we spearheaded the same effort in standardization via IEEE, starting the P1752 Open Mobile Health Working Group, which has been in existence for 3.5 years. And our the initial efforts has coalesced around the publication of the first standard that just happened this past summer for the representation of sleep and physical activity data and metadata. And I put my links on the slide for anybody interested in learning more. Thank you.
Thank you, Simona. Very, very glad to have you here with us today and looking forward to hearing more of what you have to share. So yes, next is Nick Knowlton, Vice President of Strategic Initiatives at ResMed. Nick, can you tell us a little bit about yourself and what you do there and maybe some of your work with the CareWell as well?
Thank you so much. At ResMed, we're a world-leading developer of cloud-connected medical devices and cloud-based software applications that enable hundreds of millions of patients to lead better lives. Our devices contribute data to help manage chronic conditions such as sleep apnea and COPD. Our software platforms, where I spend the bulk of my time, comprehensively serve many out-of-hospital, post-acute, and care-at-home providers, allowing them to provide world-class care for patients and the best possible experience for other stakeholders, such as their provider organizations, caregivers, family members of patients, and even payers. From a connected health and interoperability standpoint, we support running more than tens of millions of API transactions per day to help move this data around the ecosystem in a patient-centric manner. We support multiple different healthcare interoperability standards and have spent a lot of time and effort adapting standards that exist elsewhere in the healthcare ecosystem to the unique workflow and unique needs and challenges faced by post-acute providers. One of the first post-acute focused care organizations to join Commonwealth Health Alliance, and we bring a lot of passion to advocating for the needs of post-acute and out-of-hospital caregivers. Through membership in organizations such as Direct Trust, Passio Project, and others as well. And we're certainly, bring this to the real world as well to enable this to reach the boots on the ground who are, navigating the pandemic and caring for patients every day.
Thanks so much, Nick. So certainly a firsthand take on some of the major issues impacting the industry today.
Thank you.
Sure. And next up, Michael Scaff, Chief Information Officer for the Jewish Senior Living Group. Michael, can you tell us a little bit about yourself and some of the work you've done?
Certainly, Kristen. Thank you very much for having me on today. I really appreciate it. And thanks to Parks Associates as well for holding this conference. This is a really important topic. As the Chief Information Officer for this 150-year-old regional provider of skilled nursing, acute psych services, and long-term care in addition to residential services, we're squarely in the middle of the continuum between the residential services side with assisted living and memory care, and working closely with the regional hospitals for post-acute and long-term care. So as a large skilled nursing facility, we really work very closely with these hospitals around both the Bay Area and farther. And we're noticing an interesting change in the types of data that we have to exchange with our hospital partners, as well as the types of data that need to go home with our patients on the post-acute side as they go back to home after 2 to 4 weeks, and in the way we actually serve the people who live on this 9-acre campus in San Francisco in our brand new assisted living and memory care Frank residences. We have 190 units of assisted living and memory care, and we're really trying to find different ways of using our data to support really an optimal living environment and living experience for those people here, as well as start to extend services out into the community beyond our 4 walls in our Buyer Square program, which offers fitness, wellness, outpatient physical therapy, and other services. So really sitting in the center, we have seen that confluence both of services and the necessary data that are associated with that, and that transition that we're going through right now in the healthcare industry. So thank you, Kristen.
Thank you so much. And certainly a lot of exciting changes I think that you're going through, and certainly some major challenges as well.
Yes.
Yes. Next, Nico Skivansky, co-founder and president of Redox. Nico, tell us a little bit about yourself and some of the work Redox does.
Sure. Yeah, my name's Nico. I live in Boulder, Colorado, and founded Redox in about 2014 after leaving Epic. And so kind of have that EHR background in our roots. But really what Redox does is connect up the digital health ecosystem to the health systems that they work with within the workflow of the EHR, so that their applications can be integrated in a way that providers and patients can use in a much more seamless manner. And we do this at scale. So we're in about 2,500 health systems across the country now, and we see about 25 million patient records every single day going through the system. So it is a very large interoperability network that all uses the exact same data models and standards to exchange data across it. And we do that with health systems as well as with payers now, as they're being more compelled to enter this interoperability space. So we're helping them become compliant with the new regulations. And we're also doing this since COVID with public health agencies. So we manage about 10% of all of the COVID tests and sending the test result data into public health agencies so we can have accurate reporting on what's going on with the pandemic and how it spreads around. So we have about 170 employees now, and we are fully distributed across the country. So chances are there's a Redoxer near you.
Very great, very, very interesting. And certainly, I think you can expect to see some of the changes that Dr. Tripathi was talking about kind of hitting in 2022, 2023. So lots of new business maybe headed your way.
Certainly.
But yes, thank you everyone so much for joining us today, and very excited to get into our conversation. So as a reminder to the audience, before we kick things off, there is an audience polling question that you're able to access, I believe, to the right of your screen. So this is actually a repeat of a question we asked a few years ago, asking what is kind of the biggest challenge in healthcare currently. The last time we asked that question, the big answer was interoperability, the data silo issue. So I'm very curious to see what the answer is today. But yes, kind of kicking things off, Simona, so this is an area that you very much study. So what is interoperability in healthcare today? What does it really mean, and what does it do?
Thanks for the question. Is a big word. So more than what it means, I would say what it means for my perspective. Interoperability, actually, it's a complex concept. There are different types of interoperability, and I'm very focused on, in our work, we're very focused on semantic interoperability, the meaning of the data that gets transmitted. And in particular, we're working on wearable devices, mobile sensor, mobile health data. The names itself is a bit changing. So for my specific line of work and the research that I'm doing, interoperability means making sure that the data that is generated by wearable devices, or devices that are on the body or just around the body, that this data is hopefully, standard, working towards standardization. But the important thing is that the data is semantically clear, so that it can be interpreted and used properly, and also that it contains all the information that is necessary for interpretation and use. And that's the contextual information that is different depending on the kind of data. So that's my focus, with the understanding that interoperability also involves other concepts in terms of transmission of the data, of security, and other things.
Very, very interesting. And a few of you actually work directly in the interoperability space. So any kind of perspectives on what this is and how this has maybe changed?
Yeah, so I would think that we actually conducted a survey a couple of years ago regarding what the real definition of interoperability meant to stakeholders, both amongst acute, ambulatory, and post-acute providers. And actually, I was slightly surprised to learn that the HIMSS definition resonated the most. The ability of different information technology systems and software applications to communicate, exchange data, and use the information that has been exchanged. The reason that I was surprised was, especially amongst the post-acute care providers, that's a fairly technical definition. I think some of the interesting things that come out of that are that different care settings are now, moving forward and engaging areas where we have traditionally seen the green shoots of interop in acute and ambulatory care settings, and they're starting to adapt thought processes and look for ways to get their provider organizations connected in similar mechanisms to how interoperability works in the rest of the healthcare ecosystem. I think one of the key things to point out there is, the use the data portion of that definition, the ability to not just, move a document from place A to place B, but make sure that the information that's contained in that's, human readable and machine readable, can be digested and put to work. So when we talk, and Simona mentioned, semantic interoperability, and when we talk about all these unique challenges that exist within healthcare, it's important to note that the ultimate bar is not just, hey, can we get a CCDA from here to there? It's how do we do this in a manner that's aligned with provider workflows, regardless of what those provider workflows look like, and that we're harnessing the power of the data that's contained within the packages we're moving around the ecosystem.
Mm-hmm. So certainly a rich series of definitions.
Yeah, and I don't know if you can hear me, Kristen. I'd like to add the fact that, the general definition for interoperability is the ability of two or more systems to really exchange health information and use that information once it is received. But when we're talking about healthcare interoperability as a whole, it definitely will take time for all types of health IT to be fully interoperable. I think that's why we're all actually here and we all exist, right? The Redoxes of the world, the Seeksters of the world, the ResMeds of the world, the great work that UCSF has done, and the Jewish Senior Living Services that Michael was just speaking about. It doesn't matter, if you're a caregiver, a person, an enterprise, a pharmaceutical company, a provider, an EHR vendor, it could be Cerner, Epic, Allscripts. How do you get it all to kind of talk to one another? How do you harmonize that information? How do you standardize that information? And so you hit on, when you unravel interoperability as a whole, semantic interoperability, structural interoperability, and also foundational interoperability. And so, we can have a bottle of whiskey or wine and talk about interoperability all day, but I don't think there's one set definition really. There's various different definitions that go towards it depending on what type of interoperability we're talking about.
If I may, Kristen, too, I really believe that part of the issue here and part of the reason we're talking about this is there's been an explosion in the number of systems that need to be integrated, whether it's wearables, as we heard from Simona, other sort of data inputs and outputs. For a long time, it was highly siloed in different EMRs, but at least most data used to live in EMRs for a long time. Now you're seeing data all over the place, and Finally, there's some standards around the types of data that are used. Obviously, there have been standards for the exchange of data for some time, but those standards expected a certain universe of the types of data around that. And the types and disparity of types of data has increased enormously. So there's great value here in that change. Care is occurring not just in the clinical environments that it used to, and other aspects of wearables and smart homes and other things are interacting with people's lives and our care and our outcomes more than they ever have. But that's also added a lot of complexity, both to the back end on the data and also on the front end, and which is why we see services like care coordination services that have to be supported by the interoperability of data. Because while we heard from Jennifer right before this session that, for example, seniors are living at home and they need all these additional services, and their services delivering food and everything else, those services don't work well together, and they're almost impossible for one person to navigate in a coherent fashion unless, one, the back end is the back ends, plural and highly plural, are talking to each other in a standardized fashion. And also there is consistency on the front end and the experience. So both sides have to come together, both on the sort of structural and architectural elements that we're talking about here with data interoperability, and then on the front ends with how we're actually delivering these services in a coherent fashion to the people who need them.
Yes, and Michael, you definitely bring up a very good point. There has been just this exponentially increased adoption of tech by care providers. Mm-hmm. So we've seen all this adoption of telehealth platforms. There's clinical IoT. There's more at-home care. Yeah. We're beginning to hear that more and more care providers are finally beginning to integrate with, Apple Health Platform and other types of consumer-grade platforms as well. These, of course, you need to integrate with EMRs, with other clinical systems. With all these different vendors in play, how exactly are stakeholders approaching this type of integration and interoperability? And I think you have, as a stakeholder yourself, you have definitely have an opinion on that.
Well, we don't do it well, frankly. And that's why we need people that are around the room here, virtually at least, to help bring coherence to this, because it's a fragmented mess right now. It truly is. And that's why these integration solutions are so important. And to Simona's point, we need semantic coherence there too. It's not just the data structure, it's what the data means to people to actually result in good outcomes and better outcomes. It's not just structuring the data, it's making sure that those data are used effectively to result in improved outcomes. So we're going through a period of an enormous transition, both with the explosion in the number of endpoints and the number of inputs for data, but also in how we're using these data. And again, we're in this awkward sort of teenage years, if you will, of how data are acquired and then used. Again, which is why I appreciate the people around this virtual table so much, because these are the folks that I will rely upon to bring coherence to our data and therefore to the care and outcomes that we're driving, especially as care really focuses more on the home, and because that's where care is going. It's coming out of acute care, it's coming out of post-acute care, and the locus of control is shifting to the home, which without greater coherence and very careful planning is going to result in even more fragmentation.
Mm-hmm. And Nico, this is really what Redox does. So what is your take on this new type of environment we're all learning to navigate?
Yeah, something that really helps me think about this interoperability space is kind of breaking it into three different buckets. The first one is sort of what I think as the more traditional form of when people think about interoperability. It's how does data follow a patient between different care settings? Mm-hmm. So going from the nursing home to the acute care setting, will the data follow them so they can be in sync with the med list and problems and things like that? So that's kind of bucket number one. We've made a ton of progress in that over the past few years. The royal we of people working on interoperability with groups like Commonwealth and Care Quality, with HIEs, with standards around documents. So that's kind of bucket number one. Bucket number two, I call integration, which is moving data between an EHR, really, what's happening in the actual care setting, and the applications that are being used by that health system. And so this is what happens within an enterprise, within a health system. And so the health system might be using various tools for telehealth, for scheduling, for care coordination, for population health management. These are all separate, potentially separate different applications that need to share data with the EHR. And this is where Redox really comes in and helping to share that data in a way that supports the workflows. And then the third bucket, which is really an emerging bucket, but I think one that I'm most excited about, is applications that patients use directly. Because when you think about the entire healthcare system, the one common stakeholder in all of it is the patient themselves. And so they really need to be at the center of deciding where their data goes and what data is available to different stakeholders, whether that's a specialist or their payer or their family members, right? And so there's a new breed of applications that are coming to market right now that will need to draw from patient authorized access to data. And that's where Apple Health Kit plays a part. And there's other kind of middle layers that sit in between all the disparate places where your data might be and the applications that are going to be built on top of that infrastructure. So those three buckets, I think, really bring a lot of clarity to me around how to think about interoperability and the strategies that different stakeholders will take in accomplishing each of those.
Mm-hmm. Certainly some different approaches based on what your position is in the ecosystem, what you're trying to achieve.
The locus of control, though, is changing too. Sorry, Kristen, but Nico pointed out something really important. The locus of control of data has always been the health environment and the healthcare providers kind of owning your data, more or less, HIPAA aside. It's really shifting, though, to the patient. And that's where you see things like the FIRE initiative and others that are drawing the data out of EHRs traditionally and finding other places for people to actually use their data in a meaningful fashion.
Yeah, I remember, I think around 5+ years ago, there was this move in the market towards personal health records, and everyone is very excited, but it just never really was able to take off, just given all the challenges. It seems like that there is certainly more of a need for that type of a solution and maybe more of an opportunity coming up.
Yeah, and one big reason for that is because, Google and Microsoft botched that with a lot of money back in 2011. It's not because they couldn't do it. It's because they had the wrong business model and it was the wrong timing. The tailwinds were not there on interoperability. I mean, Mickey's, talk earlier from CMS-ONC was a great example of how far we came as an industry, as of interest. And then you tag along, I think what Michael stated earlier and what Nick said as well from ResMed around the fact that the pandemic has really accelerated everything at home. Health happens at home now, right? And one of I think it was Athena Health, Curtis, who presented the home-centric and family-centric type of views. Well, home-centric and family-centric views cannot exist if you don't have patient-centric technology. And that's why the patient-facing applications, are so timely now. The same way that telemedicine for 19 years, was complete crap. No one cared for it. And then, we get into a pandemic, we're all put into a box, and now I want to see Dr. Nico instead of going to Kaiser, because I can't, and I can have a nice telemedicine visit. But how do you share that medical record information? How do you break down the interoperability on my wearable data? How do you combine Garmin data with your Apple data? It's not about just one ecosystem. Right. It's way beyond that. And that's what we spent a lot of time with Seekster, really pioneering how an individual via the consent can actually seek out their health data. It's not just about getting data through Commonwealth. It's not just about using Care Quality. It's not just about getting it directly through Athena Health or Cerner. It's all of the above. And so there isn't one solution that can solve this problem. And if anyone ever tells you that they have one solution that solves the problem, they actually don't know what they're talking about. But the people here on this panel know exactly what I'm talking about because they've had the same problems as we've had, and they've looked for various different solutions to combine so that it can fit different use cases. Whether you're going provider to provider, like how Nico has just killed it with Redox on that, that's one solution for one use case. If you're dealing with provider and payer, it's totally different. If you're dealing with clinical trials, decentralized trials, it's way different. And then if you're trying to do something on the consumer side, then you're talking about different types of solutions and technology that is needed.
And they don't.
I'm not excited about this stuff at all, guys.
Well, and they don't meet in the middle. To your point, Artie.
Yeah, and it looks like Simone, you might have something to say here.
No, very interesting, of course, to hear all the panelists. I was thinking more about Nick's comment about the HIMSS definition of interoperability being very technical. And I'm now thinking maybe we should add or amend that to be more person-centric, because that's what's coming a lot out of our discussion, is that this needs to work for all the people involved. It needs to work for the patient, of course. It needs to work for their healthcare providers, and who are usually a team, not just one person. It needs to work for the caregiver, and for for the enterprise, and fundamentally for the different people. And I agree with Artie. I mean, we're not saying that there's one solution that works for everybody. We need to look at this in a holistic way, from different perspective. I think that is also part of what the last year has told us, is putting again the person at the center, handling all these different situations, and he needs whatever solution needs to work for the person, that as I said, being the patient or the care provider or anybody else that works in the space.
And then certainly we've also been hearing a lot about what we can expect in the next few years, a lot of the very exciting changes. How do we build this bridge from where we are now to that future? So we have all these data exchanges in place, health information exchanges, different EHR integrations, FHIR APIs coming out. But what really are the best practices for these types of solutions? What is kind of on the roadmap coming? So I know, Nick, in addition to the work you're doing with ResMed and Matrix Care, you're also board of the Commonwealth Health Alliance. So you definitely kind of have a perspective here on what's coming on down the pipe.
Yeah, sure. So I think my first comment would be, echoing what we've already heard from some of the other panelists, that interoperability is really complex, and it is not just about technology specifications. Every time a new specification emerges, we hear, okay, great, this will solve all these problems, and yet here we are still having panels talking about how to solve for interoperability. So I think first and foremost, we have to acknowledge that it's a journey as care continues to evolve, and certainly the pandemic is an accelerant driving that. Interoperability and what needs to happen next is going to evolve and going to change. So from the power of what has to happen beyond just technical specifications for content and transport mechanisms, there's certainly work to be done to better specify how data that exists in a patient's home or in a medical device shows up for providers in an EHR in a manner in which they want to use it, doesn't cause alert fatigue, things like that. But I do think that there is a lot of power in the power of networks as well. Interoperability requires multiple different stakeholders. It usually requires more than one technology vendor, and it can impact stakeholders, across all the different channels that healthcare is delivered today. So when you think about how many point-to-point interfaces you would have to plumb up if you actually wanted to make this work to manage patient identity, record location, trust, security, privacy, audit trails, you name it. The power of networks can be pretty impressive. So when you think about what networks like Commonwealth, what Care Equality does, what different organizations around the ecosystem can do when they actually work together and bring connectivity on top of just raw capabilities to connect, that's when you can get some real economies of scale and impact a lot of patient lives and impact a lot of care decisions for providers. So we like to think of it from the standpoint that if you had to plumb up every interface that was necessary in this country, you'd spend tens of billions of dollars and hundreds of years based on the way we do this today. But by engaging with networks and building on their successes, and I'm not just talking about HIE networks or things that look and act like Commonwealth. I'm talking about a network like what Redox has built. I'm talking about a network like what Seekster is building. They all fit within this 3D matrix of how do you turn raw technical capabilities to empowerment for stakeholders and real connectivity on a day-to-day basis. The cool thing is once you actually get these networks stood up, you're only limited by the vision that you have, right? So Commonwealth founded on patient identity and record location, but to really make it work, to really make it hum, you had to provide access to care records for providers. Well, once you do that, it's not rocket science to say, well, now you need to provide care records for patients. And it's not rocket science to say, now that you're running a record locator service at a national scale, now that event notifications are becoming mandatory and so much more expected, why can't you use those same pipes that you've already plumbed up to provide insight to providers, patients, family members, whomever, that patients had an adverse encounter, or patients, just in the course of their normal care journey, had an encounter with a specialist. When you think about these care at home models and all the device connectivity we're enabling, you still have to have basic information around what's going on with the rest of the patient. All these chronic care patients where there's so much opportunity to avert costs and improve the patient's life and patient's experience, they have multiple different problem codes associated with their name, multiple different providers they've seen, and it is really hard to keep track of that. The power of networks talking to one another and working on behalf of the patient, I think, is where we'll start to see a lot more traction in terms of solving some of those issues.
Yeah, and Nico, this is kind of Redox, does all sorts of integrations with different EHRs as well as with the health information exchanges. What opinion do you have?
Yeah, I think Nick's spot on. When you think about the challenge that's ahead of either a healthcare delivery organization or a vendor to connect to all of the different sources of data, doing it one by one will be an impossible task. Even within a given region for a healthcare organization to do that, it's so much work. So leaning on these networks is an amazing way to do it. And I'm frankly really excited about the regulations like around TEFCA, where beyond just the networks that we have, getting some formalities around those networks so those networks also connect to each other. So it won't be as much of needing to find the specific network that you need, but hopefully you can connect into one and connect to many of them. So I'm hoping to see some more teeth around that regulation in the years to come. As I think it's a really exciting prospect for the existing networks that already exist, as well as for all of the consumers of those networks to really get plugged into getting data when necessary when they're seeing a patient.
Mm-hmm. Yeah, definitely some potential to be had. So something, and we've been talking about interoperability at our Parks events for a number of years now. And something even just a few years ago that there was a lot of talk about, solutions out on the market today that really have promised to solve interoperability and the data silo problem. So kind of to what extent has this promise actually materialized for real on the ground care providers and others as well? And then Artie, I know this is kind of something that's near and dear to your heart.
Yeah, I mean, I think we've solved it. It's not even I think. I could give you access. I could give everyone who's watching this access, and you can bring all your records together within milliseconds. Happy to do that. If you have an iOS device, we just released for this conference, if you type in Seekster Health, you can bring in any provider in the country, from small doctor offices to major clinics to major health systems on any EMR, and we visualize that data as well. So we have, been spending time on the patient centricity piece ever since I filed patents in 2016 on a multi-generational health record. So my advantage was I came from the DNA sequencing side. I actually didn't come from the industry that everyone here on the call is. So before Seekster, I was tackling interoperability on the genetic sequencing side. And that was really easy because ATCG is the same whether it comes out of LabCorp, Quest, or Color Genomics, or Guardant Health, or your tumor biopsy from Foundation, or your Illumina sequencing. It's all a FASTQ file. And so when we got into working on medical data itself, because we wanted to provide a longitudinal health record in real time, not the terrestrial way where there's some other companies that basically take faxes and digitize them. That has some value if you're talking about imaging results and some other results that are heavy, that you need some sort of other technology to to place and then digitize. But really, cracking data silos starts with the patient, ends with the patient, has to be shared by the patients. It's all have to be, HIPAA compliant, obviously, and all that. But breaking down data silos at scale is a whole different discussion. So we started with one experience for one patient, and then we are able to use that experience and expand it to 10,000 patients, to 100,000 patients, and so forth. And so learning from patients and them telling us what, I guess, not to do and what to do is how we really built a scalable platform where now, anyone from ResMed to Redox to care centers such as Michael's can utilize our white label and launch a direct to consumer or patient facing application to break down those data silos. And at the end of the day, the patients own the data. We do not own the data. And that was one big reason why I started Seekster, because getting back to the genomic sequencing side of things, we came from the dark side where, labs would basically own that data and silo that data. Hence, Myriad Genetics, who, I personally fought in federal court and freed the gene patents for BRCA1 and BRCA2. And if it wasn't for that mission-driven breaking down those silos, we would have never done certain things like that within oncology. So extremely excited about where this is headed. I think we'd be 10 years behind and maybe even bankrupt if the pandemic didn't happen. The pandemic accelerated that hunger for patients actually wanting to own, control, track, and monitor their data. And you're going to see that on a whole nother level in 2022. I couldn't be more excited.
So certainly some major potential there. Simona, I'm interested in your take kind of from an academic perspective and as somebody who's been doing a lot of this types of research. And what is your perspective of kind of on the ground implementation of these things?
Well, definitely. I mean, I agree that the pandemic has accelerated the movement, and in particular, remote patient monitoring has become center, and with that, the need for data that is gathered at home by the patient to become part of the patient's story. I don't necessarily envision that merged into the EHR, but as someone was saying before, definitely this data needs to become available to the healthcare provider within the context of their workflow. And as we know, at least in this country, the workflow is EHR based. So for us, it's very exciting to work on this space. We are, we're looking for cooperation in the sense that the technology is exciting in the sense that we have new devices coming on the market, new sensors coming on the market that are able to gather more information. So it used to be that you needed a sensor for this and a sensor for that. Now we see this small devices that have several sensors and that can capture information a lot more than just the physical activity, but a lot more vital signs, a lot of this driven by the needs of the pandemic. So that's very exciting. We're still working on, our goal is to get to a standard for the data so that the data that are generated from these devices, and not all these devices are gonna go through, formal approval by the FDA, because not all the devices look at variables like, atrial fibrillation or things like that. But those are devices that the patients feel comfortable with, they like for whatever reason. So there is this bring your own device to the table situation. And so systems, more and more, the people will expect that their healthcare providers have access to these data, so that these data, which are much richer than the data that is stored in the electronic medical records, though can be seen with the electronic medical records to give a fuller picture of the person. And so our work within OpenM Health and our IEEE work is to ensuring and work together with a wide variety of stakeholders to make sure that data that is generated by these devices again is follows a standard. It has all the elements that allow then further use, and the uses for care, for research, and by the patient or the people themselves to get a sense of their health and wellness. So that's how we're focused, and we're excited because I think the more we use the data, the more the need to solve this problem at the root is felt. And the idea, and I'll finish, is to agree on standards representation for the data, and everybody uses the same standard.
Mm-hmm. So hopefully, but more of a push towards standardization, driven by this increasing need for the remote health monitoring devices, and also the bring your own device approach. Michael, so you have a kind of a unique perspective as somebody who's actually working as a care provider in these settings. Kind of, to what extent, in your mind, has interoperability kind of and the end of the data silo problem actually appeared for other care providers? So you mentioned this being kind of an issue in your business.
Well, two thoughts on this. One, we still have a soft underbelly of the industry. As much as we all want to be optimistic about this, and I am truly optimistic about this, the fact that we are all still sending faxes is not a good thing in 2021. It means that A, the workflow is broken, and B, the tools aren't good enough yet, and a few other things as well. But there's still challenges that we are still trying to overcome in terms of just basic interoperability. So let's acknowledge that, because without acknowledging that, we'll never get past it. I am optimistic for another reason, though. I've been in IT for 25 years, and enterprise IT went through a similar, roughly analogous transition a few years back in the shift from, similarly, the way sort of EMR data is now needs to be accessed by everybody else, and then it's sort of expanding beyond that data set. IT and enterprise IT went from on-premise to the cloud, as we all know. So this is a very similar analog to what happened then. And it took a number of years for that transition to happen effectively, for cloud to cloud workloads and data transfers and interoperability there to become effective, for the security and privacy aspects to be dealt with. But we have precedent for success here. So I am actually optimistic that we will be able to overcome this as well. Admittedly, there is more complexity in some ways with compliance and regulatory overhead and reimbursement and other things that will provide some headwinds to this. But for providers like us, we've had to be interoperable with the rest of the healthcare system, and there are better tools than ever before to share data between acute, post-acute, and care at home. So that those elements are already in place, and they're becoming better, and the standards are finally moving into place. The challenge is really the transitions. So it's not so much as the what and how are a problem, because we can do that to some degree. It's more in the why, and we're not doing a good transition frankly, from the different care levels, and COVID, as people have brought up here, has changed where that locus of control and where the delivery of care has become sort of the focal point. So instead of the focal point being within the four walls of an institution or a doctor's office, we're going straight to home, and we're following people home with additional tools, with remote patient monitoring, et cetera. There's some assumptions that were baked into the architecture of the data early on with EMRs that expected all of the data to be centralized. We're now in a much more decentralized world. And while the tools are there, some of the mechanisms have not yet caught up in the provider space. And some of the adoption, frankly, on our side has not yet gotten there, because we are creatures of habit, and it's hard to change what we do for a number of reasons. To catch up with some of that, to really optimize our use of the tools that, again, some of the people around this table now provide to help us.
Mm-hmm. Certainly, a lot of the technology is there. Just actually getting it implemented in a way that's meaningful and will work for real people can maybe continue to be a challenge.
and reflects the change in that locus of control and the locus of access. We serve seniors. Most seniors don't want to deal with having to have 5 different apps to control different parts of their healthcare and their wellness and everything else. They want a simplified solution. All due respect to Artie, they are not going to want to go out and seek their data. They expect their data to be collated in it for them, essentially. So as providers, we have to do some of that for them. So we're still going through a transition in how people access that and the experience that sits on top of all of this interoperability to make sure that we can deliver things and the service and care where it needs to be. But again, the tools are there. It's just part of it is the adoption. Part of it is sort of in the final steps of putting the pieces together that are on the market today.
Yeah, it's not about the people going and seeking out their health data. I think you may misunderstood what I was maybe trying to state, or you don't know enough about our technology or Seekster. Just to clarify, let's say you're Coca-Cola and you want to be a digital health company, because you should. Every company needs to be a digital health company. Why? Because look what happened in the last 2 years. Every day you turn on Fox News or CNN and there's going to be some new variants for the next 5 years. As a geneticist, I can tell you there's going to be 50 more variants coming out. So don't be scared. It's just going to be part of our life. But the key thing is, if Coca-Cola wants to enable their 200,000 employees to have some added service that can bring a 360-degree patient view and have all their health records in one place and all their data in one place, then they would utilize our technology as a white label. It would be Coca-Cola's platform where they launch our Seekster Intel Inside technology, I guess you could say. So I think the key thing is use case, how enterprises deploy the technologies to their members. If it's a big payer, for member engagement. If it's a clinical trial for a big oncology study, then it's, to get as much data retrospective from multiple different providers as fast as possible so that you can have better outcomes for your HEOR studies. And if we're talking about providers, then it's how you can, revamp their portals so that you can get a better patient experience and patient journey. So it's very important to understand the use cases and the segments and how that data is seeked out, particularly. So that's the clarification there, Michael.
One other thing, Artie, you brought up an important point, and Kristen, I think this is important to talk about as well, is one of the other focal points now is employer-driven health. As an employer, all employers are seeing a rapid escalation in healthcare costs that has only gotten worse in the last few years. So as an employer, this is sort of separate from the healthcare piece, but to Artie's point, it's why as an employer now, not that we're, again, not as a healthcare institution, but as an employer, we care more about how our employees' health is managed and monitored and maintained, because otherwise we're spending a lot more money on this. So the employers, especially the huge employers, to your point, like Coke and others, are now getting involved in healthcare, in the healthcare system, in a way they didn't before, because it directly impacts their bottom line. So there's an interesting new constituent that we are all serving, in that the healthcare providers now have to work with the employers and say, okay, your costs are escalating. How can you manage this? And so they care about how those data are managed, the outcomes and the costs associated with those outcomes as well. So that's a very interesting new angle on this as well.
Yeah, and the biggest reason for that is the pandemic again. Just go back, look, it's December 1st. We all, I'm sure, celebrated some sort of Thanksgiving with smoked turkey, deep fried turkey, I don't know, barbecue turkey, whatever you and your families did. The two things that everyone at Thanksgiving talked about was, something related to health, I guarantee you, and something related to Bitcoin. And if you weren't relating to that, then you better go get a new family, because you're not up to date to what's happening in life. So, I have strong feelings about it. Why? Because I've been seeing this from years ago, and it's happening now. We called it. And it's not just me saying that. Go see what I've written about from years ago. We knew this was going to happen. What we couldn't predict is that, a small little virus was going to shut the world down, accelerate digital health, accelerate all the great things that Nick at ResMed and Commonwealth have been doing, accelerate all the great things that Nico and Redox have been doing. It's all been accelerated. And that Coca-Cola example, again, is not a nice to have anymore. If you are not interested in digital health and overall healthcare, then what are you really doing for your own employees, your own patients, as a CEO of a bakery, let's say, or even a pizza shop? It doesn't matter what the business is. You have to care about your health. You have to be the CEO of your own health. And if you're not that first, you can't be a CEO of a startup or, an enterprise or a caring center, because you got to care about your own health first. And that is, maybe a sensitive subject, but I don't think it's as much as a sensitive subject when you have 7 billion people that know what mRNA is, and they have an opinion on whether to get vaccinated or not, but most people don't even know what DNA is still. And that's all because of the pandemic.
So yeah, certainly some interesting direction there. So yes, I think I mentioned earlier that we had a polling question that was delivered out to the audience asking them what the biggest challenge of applying data to improve care practices is. So this is a repeat of a question we asked a few years ago on another interoperability panel. Back during that panel, I believe we had over half of our audience members, maybe closer to 2/3, say that the biggest problem was healthcare silos, data in different healthcare silos. So it looks like that has actually gone down to just under 1/3 of our respondents. So definitely a big improvement. We're seeing more people say lack of data standards, kind of analytics and predictive modeling, kind of lack of reliable sources, privacy regulation, all of these different responses. So it does look like standardization in particular may be growing to become a little bit more of a challenge, especially with all this this new growth, this new multi-vendor environment, and all these new data sources as well.
Yeah, I think that there's still a lot of improvement in the data standards world, but piggybacking off of something I think I said a little bit earlier, a lot of that I think has to do with the fact that we're now trying to collect a lot more data from patients' homes, and EHRs were not built from the ground up for and that's no fault of any of the EHRs. They were built around soap processes, for instance, but being able to accommodate the data that's emerging from all the different touch points in a patient to manage chronic diseases and home-based settings and the like, that is I think a key area of focus for our industry for the next few years, is to make sure all that's represented and can be put in a user-friendly manner. Pretty much all the EHRs have the ability to ingest a document that would have that data in it, but it's not as useful that way. So I would say that is an evolution in the data standards that are necessary.
Yeah, it does certainly sound like there's going to be some more data standards coming down the pipe as well. So I guess that does kind of lead into the next question, maybe the final question of our discussion. So really, what are the as of yet unsolved issues impacting interoperability in healthcare, and how do these just get solved? Can they be solved? And this is a question that's really being aimed at everyone. So let's maybe go in kind of alphabetical order by last name, just like we did the intros. So Artie, what is kind of your perspective on this?
I think we're still trying to figure out what hasn't been solved. Interoperability is kind of like cancer. It just grows, right? Cancer is not going to be solved tomorrow. There's going to be new cancers that are coming out. Cancer grows like crazy. You can have a colonoscopy 30 times, and next thing you know, you have liver cancer somehow, but they never detected it. So, yes, new technologies are coming out the same way that within interoperability, new technologies and solutions are coming out. But I really do think collaboration is where we're getting at, and that didn't exist on interoperability before. A lot of consolidation is going to be happening in this field with multiple different technologies. And I think that is beneficial for both the enterprises, the patients, the overall healthcare expenditures, because one size doesn't fit all, and there's always missing pieces to the puzzle. So again, it's about really discovering more around what is really missing. I think there's a lot that we just don't know. It's 1995 internet era. That's what I would compare it to.
So certainly a moving target that we're all going to have to try to figure out how to hit. Simona, I'm kind of curious, what is your perspective on kind of the as of yet unsolved challenges and interoperability?
Again, my perspective is very focused on data standards, and we have data standards. We've started to coalesce around data standards, and I think there is also a push for data standards so that people can users of data can spend more time in building solutions that use the data versus spending time in trying to align data that comes from different sources. So I think the need is there. There is collaboration is obviously very important, as we just heard. I think that's very, my view again is that we should get there, because then we can spend more time in building solutions that use the data that are coming from the patients, and these solutions are going to provide care for the patient. They're going to help the physicians focus on the data that is important, and are going to help the enterprise again focus on what's important when it's important, and reduce their costs, because as we know, if we can address certain problems before they escalate, that ends up being cost saving, not in terms of money, but it also in terms of stress for the person themselves. So collaboration and really focusing for a little bit on agreeing on standards for the data, so that we can put our efforts and our creative energies more into using the data versus making them align and making sense of them.
Yeah, so standardization and collaboration is really kind of the key to driving everything forward. Nick, I'm kind of curious, what is your take?
So, a couple things. Number one, I definitely agree on data standards, especially for all the device data that we can now mobilize and need to mobilize. I would say developing more prescriptive and user-friendly pathways for transitions of care amongst maybe non-traditional care settings. Just looking at the more complex care pathways that we have for patients before they even get to the hospital, let alone the traditional waterfalls that they had coming out of the hospital, making sure that those are aligned with the specific needs of providers who don't work within those walls. And then last but not least, addressing the needs of the rise of patients as consumers. There's still a lot of really good work to be done to enable effective digital patient journeys that allow patients, their caregivers, their family members to help them navigate chronic diseases and the like. When we think about the cost burden of healthcare and everything, that's where there's a lot of opportunity to attack big problems next, I think.
Mm-hmm. So yeah, certainly some movement that could be made there as well. Michael, kind of, I would like to hear what your view is. Kind of again, a little bit of a unique perspective among the panelists here.
I'm optimistic, I think, about the standards primarily, because I think there's enough understanding of what is necessary in those standards that they will be successful, at least in their development. It's in their adoption and adherence, because there's a natural tension that also exists in business, as we know, between standards-based approaches and proprietary approaches. And inherently, some companies see more value in either staying proprietary or in not making it easy for the data to flow in multiple directions. So I think we still have some directional challenges that we'll still face, but again, I'm optimistic because I think we have the right focus on building those standards and then hopefully utilizing them effectively. I just think we have a few sort of speed bumps that we have to still face to get there, because I agree with Artie as well. Things will continue to change. If we can agree upon a generalized methodology for how we deal with that change, we'll be more successful there, because that will help us evolve and adapt to the new inputs and outputs that come to the scene that we haven't even thought of yet. But it's more in the common agreement and collaboration around how we do this, and that we are going to make sure data flows in the multiple directions it now needs to, that will be that sort of headwind, at least, to getting there.
Yes, and thankfully it does seem like regulators in the UNC are at least poking the industry in the right direction.
Yeah.
Nico, it looks like we get to hear your closing thoughts.
Nice.
So no pressure.
Yeah, so I'd love to just piggyback on the standards discussion. It's so funny. I feel like, I don't know if anyone has said the word FHIR since we started, but we have a new standard that's being adopted and it's being used, and Redox is certainly supporting it. But one of the things that I think is preventing us from full adoption of it is we still have these old standards that are highly used across the country, and we're not going to adopt the new ones fully and fully embrace them and have them fully encompass all of the use cases that are necessary until we actually stop using the old ones. So regulation, beyond forcing us to use new standards, should probably also start retiring some of the old standards that are in use across the country. So that's number one. Number two, and finally, I think a big thing that's preventing widespread interoperability, kind of piggybacking on Nick's comment with consumers, is that we are working with an out-of-date privacy and security laws within the United States. We don't have anything like GDPR that regulates every single organization that touches patient data to ensure that patients know that their data is in those are in those locations, and gives the patient really access and controls over figuring out where their data is and how their data should be moved between different organizations. And I think without that, we're kind of operating in the dark as far as how to develop an ecosystem where consumers can have power to enable interoperability across the multiple care settings and applications that are going to be touching their data. So those are the two things that I would say are kind of holding us back at this point, the unsolved problems in our space.
Yes, I know I've certainly talked to a few kind of global players, and their perspective is that they are expecting to see more and more countries roll out GDPR-like protections around kind of personal data and especially patient data. So they just aren't, there's a lot of uncertainty around what that is eventually going to look like. But yes, thank you all so very much for joining us here today. It was a wonderful discussion. It was great hearing from everyone. Definitely learned a lot. If you are able, we do have these networking breakout rooms that I believe the links will be posted for in the chat, so we can continue our discussion there. Maybe hear from some audience members, any questions they might have. But yes, again, thank you all so very much, audience members, for attending our final day for the Connected Health Summit. It's been certainly a very interesting year, hearing a lot about all of these very radical changes happening in the healthcare space. Again, I'd like to give a thank you to our sponsors, Alarm.com, Essence, and Everrise for really helping to make this event possible. Definitely appreciate your helping us to do all this very great research and hearing from all of these different players on the market. Yes, again, thanks to Alarm.com for your sponsorship. As a reminder, we do have some new connected health research out that you are able to go and purchase off the shelf, including some of our consumer survey work around virtual care and connected health devices, senior assisted living, an upcoming report on the connected health market as a whole, as well as our smartwatch market assessment, which should be published shortly. Again, if you have any syndicated or custom research needs, be sure to reach out as well. We will be meeting again in 2022 for another virtual series, as well as an in-person event scheduled for September. And hoping that you are all going to join us in the virtual networking rooms in Zoom. Thank you, everyone, and hope you have a great holidays and rest of the year.